Morning to all.
And good evening to Sapna.
Yeah, yes, of course, sir. And this program is organized by the same KSHEMA Alumni Association along with the Internal Quality Assurance Cell. And when we decided to organize this program, our main intention was so that there is a disconnect, what you can so that the disconnect between the students who have passed out as well as those who are present in the college and the faculty. Along, as we all know, 20 years ago, when the first stone was laid here in Derlakate, nobody knew who all will be, how the life will be a couple of years later, and how we will be proceeding with our life. And now we now know that many people have grown bigger and some even bigger and at different places in the world, maybe in our place and international and national level. And even our teachers, for example, have grown from the faculty level to the highest level. For example, we have Dean sir and JP sir. I still remember all of them being as our teachers in our college days. And this is our main intention, so that the students who are also in our college gets motivated and they get a proper direction to different fields in the medical fraternity, because they should not get confused like where to go, where to travel from once they leave the parent institution. Most of us, maybe we didn't have any proper guidance. We were told the names of the first batch and second batch of us, the KSHEMA batch, way back in 99, 2000. We didn't know where the library is, actually how college should be. But it has changed. And now if you see the institution, it is tremendous and significant changes have happened in our institution. And today we have two stakeholders in the field of immunotherapy and the oncology to give who has consented to be here with us and to give mainly the expertise in their field. And to begin with, I can say that our beloved Dean, Dr. Professor P.S. Prakash sir, has agreed to be a part of today's program, and he has agreed to be the chief guest. And it's one of the most important things for us, because we all started together with him, and it is very glad to see him here. And I, on behalf of KSHEMA Alumni Association, welcome you to the program, sir.
Thank you. Thank you.
And also,
yes,
the Vice Deans, Dr. Jayaprakash sir and Amrit Muradkar sir are also here, and I welcome you to the program, sir.
Thank you. Thank you.
The program cannot be successful without a proper preparation and the acceptance from the speakers. And we have our own alumni from our batch 99 and 2000, Dr. Santosh K. Devdas and Dr. Swapna Devana, to give a speech on immunotherapy and topics related to that. I, on behalf of KSHEMA Alumni Association, welcome to the program, Santosh and Devana.
Thank you.
Also, yes. And I also welcome all the faculty from different departments, including head of the department, and the students who are present here and who are patiently and interestingly, they have come here to listen to the program. More importantly, I should also thank the moderators for the day, Dr. Vijit Shetty from the Department of Oncology, who is the Associate Professor, and also his wife and our Associate Professor in the Department of Medicine, Dr. Aditi Bandari, for agreeing and consenting to be the moderator for the day.
Thank you, sir.
Now, thank you, Vijit. Now I request our beloved Dean, Dr. P.S. Prakash, to address the gathering.
Good morning once again, and to all of you, and good evening, Swapna. It's a proud moment for a teacher, for their teachers, to see their students' achievement. I still remember having taught many of you, and I think that 10th, 11th, and 12th counter, you people coming for the bedside clinics, and I throwing my tantrums and all these things, but I had a great time. I myself evolved from when I joined this institution in 2002, joined as an associate professor. And later on, I took over the head of the department next 3 years. And now I achieved this position of dean as far as the college, which is the highest position. And this is all because of you people. See, teachers, you, the students, make the teachers. Without students, there can't be teachers. And today, seeing all of you achieved your achievements, I'm certainly proud that my profession, what I wanted to achieve, has been achieved. Many of you are in a very high positions, still in the going to higher positions, and in fact, if Dr. Pretty Ratnakar, who is a second batch student, she is now head of department of anatomy, and she sits me in the college council next to me. What else a teacher expects? That's a proud moment for a teacher. And yeah, Swapna.
No, thank you, sir. I said it's me, Pretty, sir.
In fact, looking all of you doing so well, really proud. And my day, as I initially said, my day has been done. And also, I think I have achieved something in maybe a couple of 1 or 2 years left in my professional career. I go with a proud moment that I have taught so many of you. Of course, we can only guide, teachers can only guide, but it is your hard work, your sincerity, and your passion for your profession, which has taken you to this position. At the same time, I also note, yesterday I called for all the list of students. I wished more number of students would have joined today's this thing, but anyhow, this is a beginning we have made, and it's a good beginning we have made. And I request all the alumni associations, office bearers, to arrange such programs more often. At least every quarter, there can be a program, if possible, every quarter, and more number of people coming into this. And also, I think the MBBS students, we need to give them wide publicity to join, to see their seniors, their own alma mater, what they have achieved, and by their sheer hard work, I think that would go a long way in infusing or in enhancing the reputation of the institution. So with these few words, I think I'm very proud of all your achievements. Very nice to see you. Of course, I was just telling Rachna Madam, if all of them would have come on the camera, we could have seen how they look at what were they when had their picture and what are they now. Definitely, it would be a pleasure. Anyhow, I wish great success. I thank Dr. Ashwin and Dr. Nikhil and today's moderators, Dr. Vijit and Dr. Aditi, and guest speakers, Santosh and Swapna. That thank you very much for accepting this invitation and starting a beginning. And I end my this thing again with a request to see that such programs are organized more often and more number of students are involved. Thank you very much. Have a nice day for everyone. Yes. Nikhil?
Thank you, sir, for your kind words. And now I request Nikhil Shetty to introduce today's speakers.
Good morning, everyone. It's a pleasure to introduce the two speakers, Dr. Santosh and Dr. Swapna. Both of them are my dear friends. I'll be starting with the introduction of Dr. Swapna Devanna. Dr. Swapna Devanna is a board-certified hematologist and an oncologist with a keen interest in lung, gastrointestinal, and malignant hematology. Currently, she is working at the Alumni Health Cancer Institute, St. Paul, Minneapolis, USA. Dr. Swapna Devanna, she did her MBBS from KSHEMA Medical Academy, Mangalore, from the 2000 batch. She then did her internal medicine residency at the South Illinois University, Springfield, USA, followed by her hematology and oncology fellowship at the University of Missouri, Columbia, Missouri, from 2015 to 2018. She has worked at many places during her residency, starting from the Southern Illinois University Midwest Regional Medical Center. She's got a host of a long list of publications to her credit, and she's certified in ABIM Internal Medicine Board, ABIM Oncology Board certified, and ABIM Hematology Board certified. We at the alumni team and the internal quality control team would like to welcome you on board for today's talk. Coming to the second speaker, that is Dr. Santosh. It's an honor and a privilege to introduce your own batchmate. Dr. Santosh, he's done his MBBS. He's from the first batch of KSHEMA, 99. He then did his MD medicine from St. John's Medical College, followed by his 3-year fellowship in medical oncology at Tata Memorial Hospital, Mumbai. He's currently working as an associate professor and the chief of bone marrow transplant at Ramaya Hospital. He's worked in a lot of places. He's been awarded around fellowships of around 10. I mean, he's done everything in dozens. He's got a dozen of awards, 2 dozen of publications, and he's got international and national presentations. That's also in dozens. And he's a part of many sponsored clinical trials. It's really a proud privilege to welcome Dr. Santosh for the talk today. Welcome to both the speakers.
Thank you, Nikhil, for the kind introduction.
Thank you for the warm introduction. Thank you so much.
Sorry. Having done with our introductory aspect, I now request the moderators to start on with today's topic.
Thanks, Dr. Nikhil. We have reached a long way from the era of chemotherapy to targeted therapy, and now moving on to immunotherapy in non-small cell lung cancer space. So I'm sure Dr. Sapna is eager to present slides and show us the way forward. So over to Dr. Sapna to start the proceedings. Looking forward for an interesting session.
Absolutely. Are you able to see my slide?
Yes, it's clear.
Yeah, yes.
So basically, I wanted to first thank everyone, including Dean, Vice Dean, KSHEMA Alumni, and IQAC KSHEMA Association organizers for this, first of all, for inviting me as a speaker and also for this opportunity. Wonderful opportunity. So today we're going to talk about immunotherapy in non-small cell lung cancer. So let's begin. So I have no disclosures. So today's agenda is going to be, I'm going to briefly touch base on the lung cancer screening, and then we're going to move on to impact and timeline of immunotherapy, role of immunotherapy in metastatic non-small cell lung cancer, role of immunotherapy in multimodality setting, and future perspectives. So lung cancer is a leading cause of death worldwide with an estimate of 2 million deaths. Historically speaking, most lung cancers are diagnosed at advanced stage and have distant metastasis at time of diagnosis. So that raises an issue for screening. So low-dose CT scan is a wonderful tool for detecting early-stage lung cancer in heavy smokers. It's very safe, quick, and no IV contrast is needed. Finds lung nodules that can be followed, and if growth is seen and it's suspicious for cancer, needs further workup. Studies have shown that low-dose CT scan screening decreases lung cancer death in heavy smokers. So who gets screened? patients aged between 55 to 80 years of age who are current smokers or have quit within the last 15 years and have at least smoked 30-pack year history of smoking. As we all know, smoking is a major risk factor for lung cancer, and there's usually a lag time of about 15 years from the time of the exposure to smoking and then development of the lung cancer. On the right, you see a comparison of low-dose CT scan done on screening. And the first image depicts a new lung nodule that wasn't there a year back. The second one shows that there's an interval development of the lung nodule. So this then gets worked up for cancer. So coming to the cancer death and cigarette smoking. So this study done in US shows that the lung cancer death rate will decline as the cigarette smoking declines. So you can see this light green, this is the smoking consumption, and that declines, and there's a male and female population with the decline in the lung cancer death. So it's important to educate your patients to quit smoking. So almost every patient gets for diagnosis and staging CT chest with IV contrast, FTG AVID PET CT scan, brain MRI, except for stage 1A, diagnostic biopsies or surgery, EBUS plus bronchoscopy for mediastinal staging and molecular testing. In recent times, the pulmonologists at my facilities have used new technology called as ION, robotic assisted device for staging and biopsy purpose at the same time. So mainly for the stage 3 non-small cell lung cancers, multidisciplinary approach is important, and a discussion in the tumor board. So just briefly about the TNM staging, this stands for tumor, node, and metastatic, and this is important to decide the next steps. So the first 4 just shows the tumor size, and based on the tumor size and the extent of the disease, the T staging is categorized. And then coming down to the lymph nodes staging, and you can see that, sorry about that. The lymph nodes, if it's local, then it's N1. And when the lymph nodes are in the mediastinal area in the ipsilateral side of the lung nodule, and if they are in the subcarinal space, that is N2 disease. And then N3 is when the lymph nodes on the other side of the lung, contralateral side, and when it reaches the supraclavicular lymph nodes. So when we say stage 4, it's already metastasized from the chest and out towards the brain, bones, liver, and so forth. So management of locally advanced resectable non-small cell lung cancer need multidisciplinary discussion. The surgical opinion typically determines the overall approach. Typically, patients with N1 and 0 N1, they go in for surgery and then adjuvant chemotherapy. Patients with N2, we discuss in the tumor board, and if the surgeon thinks that it's technically feasible to resect them, then they go in for surgery. If not, then they are named unresectable, and then they proceed with chemoradiation. And N3 disease standard of care is concurrent chemoradiation. So these standard of care cure some, but not all. And most patients eventually have progressive disease and die from metastatic disease. So coming to this table of prognosis by stage in non-small cell lung cancer. And in this table, we can see that the 5-year overall survival for stage 3A patients, let's start with stage 2B, it's 53%. So half of patients won't make it beyond 5 years once they're diagnosed stage 2B. Then coming to stage A, the 5-year overall survival is 36, and then 26 and 13 thereon. And much worse for stage 4 disease, where patients only survive for less than a year, probably only a few months. So we have to do something more to improve overall survival, and we are always looking for ways to improve this. So entry of the targeted therapy and immunotherapy has changed the small cell lung cancer treatment paradigm and has helped our patients to live longer with improved progression-free survival. So going back to 15 years, essentially everybody got treated with same chemotherapy. Without treatment, patients lived only for less than 1 year. And now, now we have targeted therapy, PDL1 therapy. So that being said, if patient happens to have an targetable mutation like EGFR ALK, they are living for years and years. And about 30% have the targetable mutations, but what about those rest of the patients? So the immunotherapy have rapidly evolved to fill that void. If there is a no targetable mutation, now we have immunotherapy, which shows similar tail to the end of the curve, extending survival in non-small cell lung cancer. These patients were see, these patients here were patients here many years back, now living much, much longer. So if there is no targetable mutation, as I told you, immunotherapy shows similar tail to the end of the curve and improves survival. Today, nearly everyone with non-small cell lung cancer, which accounts to the vast majority of lung cancer cases, have therapeutic options. People with advanced and metastatic non-small cell lung cancer that respond to targeted therapy or checkpoint inhibitors now routinely survive for 3 to 4 years of diagnosis, and lucky few can actually substantially live longer. So there's this study, CA209003 study demonstrated an estimated 5-year overall survival of 16% for patients who are previously treated with Nivolumab. And also another study also investigated the Pembrolizumab in long-term survival data, which showed that patients lived longer in both treatment-naive and previously treated advanced non-small cell lung cancer patients with 5-year overall survival rate of 23% versus 13%. More so with PDL1, more than 50%, with the 5-year overall survival rate of 29% versus 25%. So immunotherapy has revolutionized the therapeutic landscape of patients with lethal disease like lung cancer. So coming to the history behind immunotherapy, Dr. Kohli is the man behind birth of immunotherapy in oncology. This paper actually was published in New York Times in 1900s about Dr. Kohli and birth of immunotherapy. So Dr. Kohli's interest started when he encountered a gentleman 7 years after the patient underwent a surgery for sarcoma, which was originally deemed extensive and unresectable. However, shortly after the patient had the surgery, he developed this infection called as erysipelas, and the tumor disappeared. So Dr. Kohli got interested in this strategy and wanted to try this on his patients. So he originally injected this infection into his cancer patients, and he saw that the patient truly developed this infection erysipelas, and by the time the infection cleared in 10 days, the tumor disappeared. So this paper was published in 1893, and that was his first patient was still alive at that point. That's 2 years after her getting this treated with infection. So immunotherapy timeline, I think there has been a rapid explosion of FDA-approved immunotherapy since 2015 in treatment of lung cancer. In 2015, Nivo entered the game as second-line option for treatment of advanced non-small cell lung cancer. And then soon followed a landmark trial, KEYNOTE-24, in 2016, when Pembrolizumab got approved in the first-line setting for patients with PDL1 more than 50%. PDL stands for program depth ligand and more than 50% in advanced non-small cell lung cancer, which set the stage for immunotherapy in the first-line setting. Soon, multiple trials, approvals, which has changed the paradigm of non-small cell lung cancer treatment. So how does the immunotherapy work? So two mechanisms, CTLA pathway and programmed cell death protein 1 pathway. So many tumors protect themselves by exploiting the immune system, natural safeguard. And let me get to this picture here. And you can see this is a T cell which has this checkpoint protein called as PDL1. The tumor has many production of PDL1, and that kind of blocks this checkpoint safeguard mechanism that we have, and causes it basically lose the immune system into a dormant state, and just prevents it from destroying the cancer cells. So basically what the anti-PDL1 or PDL1 and PD1 blocker does is basically goes and binds in this location, preventing it from binding, and then unleashing the immune system to go and fight the cancer. So as you can see on the right side here, the approved PD1 blockers, Nivolumab and Pembrolizumab, Ipilimumab, and then PDL1 blockers, Ipilimumab and Durvalumab, and anti-CTLA4 Ipilimumab. And the new kid on the block on the anti-PD1 is Ipilimumab. So who will respond is a big question. Who responds to this immunotherapy? And we still don't have great markers of that, but what we have is PDL1 currently. And this kind of help to decide what would be the first line choice for our patients. This PDL1 is scored based on the amount, and low score is less than 1%, and the intermediate score between 1 to 49, and high score of more than 50%. So this biomarker helps us decide who is likely to benefit from the immunotherapy. Higher the PDL1, more the benefit. Coming to this, the next one, the smoking history. So why does that matter? The non-smokers tend to have druggable mutations. They can have EGFR, ALK, ROS, all these are druggable oncogenes. And the smokers tend to have high tumor burden and tend to respond better to immunotherapy. So there's very little overlap between these two entities. So it's a reason why it's very important to rule out if there is a targetable oncogene. So with all the advances and the approvals in the management of advanced frontline treatment is getting very complex, and it needs to be personalized for your patient. Again, treatments as a single agent, combination with chemotherapy, just two dual immunotherapies, and combination of chemo, biologicals plus chemotherapy. All these are approved in non-small cell lung cancer patients with advanced disease. So as you can see, I just took a snapshot of this NCCN guidelines to just show the explosion, the amount of immunotherapy that has been approved in the first line setting. This is all that is approved for patients with more than PDL1 more than 50%. This one for the intermediate score, and then coming to the patients even without the PDL1. This is adenocarcinoma, and this is for the squamous cell. So immunotherapy, when first developed, was used as a salvage in the second line setting. So tons of data in that line. Immunotherapy has shown to be better than chemotherapy. You can see the bottom line there, median overall survival in months. And basically now Nivo, Pem, Atizo, all approved in the second line treatment. This is a landmark trial. Let's talk about this trial. KEYNOTE-24 phase 3 study that compared Pembrolizumab and with platinum-based chemotherapy in patients previously untreated advanced non-small cell lung cancer with PDL1 50% or greater without the targetable mutations. Patients were randomized to receive either Pembrolizumab at 200 milligram every 3 weeks or a choice of platinum-based chemotherapy. Pembrolizumab was associated with improved response rate, 44% versus 27%, and a median progression-free survival, as you can see in this chart here, with a hazard ratio of 0.5. That's 10 months over 6 months for the Pembro compared to chemo arm, and the estimated overall survival at 12 months was 70 versus 54 months. This is a great response. So this is an updated slide for overall survival, which continues to show that the overall survival at 24 months is 51% in Pembro arm and then 34% in control arm, with a median survival in months 30 versus 14. So 81% crossover to pembrolizumab with prolonged follow-up. Overall survival benefits were maintained despite the crossover from the control arm to the pembrolizumab. Again, won't go into much. There's another trial, Impower 110 trial, which looked into atezo plus chemo in the same set of population with a high PDL1, and again showed improved overall survival and progression-free survival. So this is a next one that that I want to talk about, but this was a negative study. They wanted to see if what happens to the low expressors. So Nivolumab was studied in the first-line setting for PDL1 less than 5%, and here there was no progression-free survival benefit nor the overall survival benefit. So at this point in time, we have 3 FDA-approved immunotherapies as a single agent for first-line therapies in patients with advanced small cell lung cancer in high PDL1. Those are Pembrolizumab, Ipilimumab, and Nivolumab. So this is KEYNOTE-042 trial. This was a phase 3 KEYNOTE-042 trial. Further investigated the efficacy of Pembrolizumab as first-line therapy in patients with PDL1 of more than or equal to 1% and negative for EGFR and ALK. Patients were randomized to receive either pembrolizumab at flat dose of 200 milligram every 3 weeks for up to 35 weeks, or a choice of platinum-based chemotherapy for 4 to 6 cycles. So pembrolizumab demonstrated significant prolonged median overall survival in all 3 PDL1. However, in patients with PDL1 ranging from 1 to 49, in this bottom slide, you can see that there is no overall survival, did not lead to overall survival benefit. So that's the reason we think that the patients with this patients with the PDL1 less than more than 1% was thought to be mainly driven by benefits from the PDL1 more than 50% patient population in this study. They had more PDL1, more than 50% patients, like I think more than 40%, 47% or something like that. But that was higher than what we would see in a clinical setting, which is about 33%. So despite this, the FDA still approved the pembrolizumab for the first-line treatment of advanced non-small cell lung cancer patients with PDL1 more than 1% with wild type. So let's talk about combos with chemo. So immunotherapy with chemotherapy. And this is a KEYNOTE-189 trial, which looked into chemotherapy and pembrolizumab combination in patients with PDL1 less than 1% non-squamous. This is a global double-blinded study, placebo-controlled. Again, a combination of chemotherapy and immunotherapy versus chemotherapy alone. This was regardless of PDL1 expression. So basically, the patients were assigned to pemetrexed and a platinum-based drug, plus either a pembrolizumab or placebo every 3 weeks for 4 cycles, followed by pembrolizumab or placebo for up to a total of 35 cycles, plus pemetrexed maintenance therapy. Estimated rate of overall survival at 12 months was 69% in pembrolizumab combination and versus 49% in the placebo combination group. Median progression-free survival was 18.8 months in Pembro group versus 49.9 months in the placebo group. So surprisingly, shows improvement, overall survival improvement in all patients. However, greatest benefits are seen with patients in PDL1 more than 50%. So final analysis of KEYNOTE-189 was reported that pembrolizumab plus chemotherapy continued to show improved overall survival. And this benefit was seen across all levels of PDL1 expression. So I won't go into much detail about this. This is Impower 130 trial, which looked into atezo and chemo combination, again, improved overall survival. And the conclusion from this study is basically in intention treated population with wild type atezo plus chemo, improved overall survival, progression-free survival compared to chemo alone, which was maintained across all subgroups. This is Impower 150 trial where quadruplets were used. That means a biological was added to chemotherapy along with immunotherapy. And basically they randomized atezolizumab, bev, carbo, and paclitaxel, and then just atezo, carboplatin, paclitaxel, or just the bev, carboplatin, and paclitaxel. So basically compared with bev chemo doublet arm, atezo plus bev plus chemo arm resulted in significantly improved median progression-free survival. So that was 8.4 versus 6.8 months. And the overall survival, 19.8 versus 14.9 months. The median overall survival was numerically longer in the ACP group than the BCP group, but lacked statistical significance, so longer follow-up is needed in this ACP group. At present, the FDA has approved the quadruplet. That's the category 1 recommendation. And then there's also option for just the atezo combination with carboplatin and paclitaxel, nab-paclitaxel for the treatment naive patients with advanced non-small cell lung cancer with wild type. So again, another trial with combination chemo, atezo, Impower 131. This looked into squamous cell histology, again, improved benefit and approved. KEYNOTE-407, again, looked into squamous histology, specifically at the squamous histology, but here the combination was pembrolizumab plus chemotherapy. And again, good response to treatments. This is currently Pembro plus chemo has been approved by the FDA as first-line treatment strategy in patients with non-squamous and squamous histology, regardless of PDL1 expression. So what about the immuno combinations? So somebody who wants to have a chemo-free approach, then this would be the way to go. So Checkmate trial 227, first-line Nivo plus chemo approved with in patients with PDL1 more than 1%. So basically, this investigated the role of dual immunotherapy in first line. Part 1 of the study had 2 independent primary endpoints. One was progression-free survival with Nivo plus Ipi versus chemotherapy in patients with high tumor mutational burden. That's more than 10 mutations per megabase. The other was overall survival with Nivolumab plus Ipi versus chemotherapy in patients with PDL1 more than 1%. So in patients with high tumor burden, Nivo plus Ipi significantly improved progression-free survival, as you can see, and that was regardless of the PDL1 expression. So we can see here that progression-free survival was 27% versus 8% with a hazard ratio of 0.56. Median progression-free survival was 6.2 versus 5.3, and again, regardless of the PDL1 expression. Going a little more into future, after 54.8 months, median overall survival remained longer with Nivo plus Epi during versus chemo in patients with PDL1 more than 1%. So 4-year overall rate with Nivo plus Epi versus, Nivo plus Epi versus chemo alone was 29% in PDL1 more than 1% versus 18%. This trial basically looked into combo immunotherapy plus just 2 cycles of chemotherapy. This study, encouragingly, dual immunotherapy plus limited course of chemo resulted in significant improvement in overall survival. That's 15 months versus 10.9 months with a hazard ratio of 0.66. Furthermore, the survival benefits were regardless of the histology and the PDL1 expression in this trial. FDA has approved this combination therapy for treatment-naive advanced non-small cell lung cancer treatments without ALK and EGFR alterations. Again, with all these advances, it's very complex and it's hard to determine which would be the first best therapeutic option for your patient. Let's go into what would be my recommendation for patients who have PDL1 and more than 50%. So there is several network meta-analysis has been reported which demonstrated that combination of pembro plus chemo did improve overall response rate and progression-free survival, but again did not have a significant difference in overall survival. So furthermore, combination therapy was also associated with increased side effects. Therefore, the treatment decision should be really made to balance the relative risk and benefits. So in patients with the PDL1 more than 50%, my first line approach would be single agent immunotherapy. And if they're elderly and are poor performance status, less than even 2, I would say immunotherapy single agent. And patients with high tumor burden, I would use a combination and add chemotherapy in there so that there will be a higher response rate. And that may also help patient to have a tumor, significant tumor remission and symptom relief, and potentially hamper the hyperprogression. So how about PDL1 more than 1%? So in this set of patients, I would like to use the combination of chemo plus immunotherapy in both high or low tumor mutational burden. And patients who are unfit for chemotherapy, obviously we have the immunotherapy as a single agent to be used. PDL1 negative, my take on this would be a combination again for high tumor mutational burden patients, but if they have a low tumor mutational burden, the immunotherapy, there's no real indication to add them, and I would just use the chemotherapy in those set of patients. Coming to the very interesting topic, the immunotherapy in multimodality strategy. So far, we talked about the advanced in immunotherapy in advanced metastatic small cell lung cancer patients, but here is the interesting portion of this talk. So PACIFIC trial, this is a trial that randomized patients to receive Durvalumab, 10 milligram per kilogram every 2 weeks, or a placebo for 1 year in patients with stage 3 non-small cell lung cancer who did not have a disease progression after 2 or more cycles of chemo, concurrent chemo RT. So 3-year overall survival was not reached for Durvalumab versus 29 months for placebo with hazard ratio of 0.69. Progression-free survival improved to 16.8 months with Durvalumab versus 5.6 months with the placebo. And overall survival at 36 months follow-up was that Durva group did better, 57 versus 43.5%. This drug was approved in February 2018 as a consolidation treatment after concurrent chemoradiation for stage 3 non-small cell lung cancer. Again, this is
Dr. Swapna, Dr. Vijit here, and we are running short of time. If we could probably wind up the session. Sorry to interrupt.
Sorry?
We are running short of time. If we could probably reach the, because we have one more speaker waiting,
Yes.
Dr. Santosh. So if we could
Wrap up.
Wrap up, yeah.
Yes, okay, that sounds good. So this is basically an adjuvant trial, Checkmate trial. This is new, just 2 months back, new adjuvant setting, which has been recently approved in May. Autoimmune related side effects, you have my slides to go over. Treatment is steroids, some special population, and just unanswered questions and some future perspectives. So that being said, thank you for listening. It was a long talk, extensive information, and I'll be happy to take any questions.
Thanks a lot, Dr. Swapna. That was a very insightful talk, actually. Being a medical oncologist practicing immunotherapy, it was very interesting for me to get so many perspectives from you. And just that last slide was very interesting, where I think neoadjuvant immunotherapy is also making inroads now. So from metastatic setting, we are moving toward the adjuvant and as well as neoadjuvant setting now. What, in your experience, is the most common side effect with these immunotherapy drugs? Is it the pneumonitis, pulmonary toxicity, or is it the endocrinopathy? So what are the common side effects that you encounter in your practice?
So the most common ones I encounter is pneumonitis, rash, and hypothyroidism. Sometimes we have also seen colitis. So these are the ones I have encountered as the most common ones.
Right. I think that's almost the same kind of side effect we see here. We see a lot of hypothyroidism and pulmonary toxicity also, especially in those who have received radiotherapy in the adjuvant setting. Yeah, and I think all the NCCN and the ESMO guidelines are slowly pushing for immunotherapy in all the settings. Having said that, we have a lot of patients on chemotherapy alone on pemetrexed maintenance doing well in the adenocarcinoma setting. So thanks a lot, Dr. Swapna. So if there are no more questions, I would probably request Dr. Santosh to give his talk on stem cell transplant.
Thanks, Vijit. Am I audible?
Yes, Santosh. And before you begin, it's heartening to know. I think Dr. Santosh is one of the very few medical oncologists who's doing stem cell transplants, where most of us are trying to run away from transplant. Dr. Santosh is passionately following stem cell transplant, and he has recently concluded more than 100 transplants in his institute. So, hearty congratulations, Dr. Santosh. Keep up the great work. We are all following you. It's a great privilege to know you in person. So,
thank you, thank you, Dr. Vijit, for the kind introduction. In the next 20 minutes or so, without much ado, I will just kind of give a flavor of the kind of work we do and about hematopoietic stem cell transplantation, or also called more commonly called as bone marrow transplantation. So this is the overview, a short introduction followed by stem cell sources, indication and process that we use in transplantation. More about allogenic transplantation, followed by a bit about auto transplants. What is a stem cell transplant? It is, simply put, it is a replacement of patient's hematopoietic stem cells with a more healthy source from another source. The major two types of transplant, that is allogenic and autologous. In allogenic, if the stem cell source is from an identical twin, it is called a syngeneic. If it is a HLA identical related donor or an unrelated HLA identical donor, it is called allogenic. If it is from the umbilical cord, it's called a cord blood transplant. And if the donor is a half-matched family donor, it is called a haploidentical transplant. So just the broad message of the talk, what is hematopoietic stem cell transplant? It is a procedure. It is the name for the whole procedure. And the drug that we use is cells. The stem cells that we give is the drug that works. And it is a multi-speciality care that one has to look into over a prolonged period of time, where the patient stays with the physician for a long period of time. And mind you, it is the only transplant that is done by physicians and not by surgeons. So Sir E. Donald Thomas was the first one to pursue this field, and he did the first successful stem cell transplant for acute leukemias. And he was awarded the Nobel Prize for Medicine in the year 1990 for this achievement. So this transplant started in the United States in the early 80s, and the first transplant was done in our country in 1983 at the Tata Memorial Center. And in recent times, every year about 25,000 transplants happen in the West, and in India we do about 2,000 transplants a year. though the requirement is nearly 100,000 transplants a year for our country. Do transplants work? They definitely work. This is a picture of Nancy King Mclain, who is 52 years old now and is the oldest transplant survivor, and she received a transplant when she was a kid. The number of transplants done all over the world keep on increasing each year. So what do we transplant? We transplant hematopoietic stem cells, which are adult stem cells, have the ability to self-regenerate, and they generate body's blood cells, that is white cells, platelets, and the red cells. So the hematopoietic stem cell is a transplantable product. The sources are the bone marrow itself can be a source. The more common source is the peripheral blood harvest. The other less commonly used source is the umbilical cord blood. How do we collect the stem cells? We in a bone marrow harvest, we take the donor to the operation theater, give general anesthesia, and harvest from the posterior superior iliac spine. The more commonly used, more easily done procedure is the peripheral blood stem cell harvest, where we give granulocyte colony stimulating factor to the donor for 4 days, and on the 5th day, the CD34 positive stem cells come from the bone marrow into the peripheral blood, and the stem cells are collected from the peripheral vein. The stem cells are separated in a machine that is designed for this, and the remaining components of the blood are reinfused back simultaneously into the patient. Which is a better source? More and more peripheral blood stem cell source is being accepted, except for few benign diseases where bone marrow harvest is preferred, mainly because with respect to the recipient, the peripheral blood stem cell harvest leads to better earlier engraftment, better immune reconstitution, better graft versus tumor effect. However, the disadvantage is that there is a slightly increased risk of what we call as a graft versus host disease that we see in some of the patients who undergo allogenic stem cell transplantation. From the donor's perspective, definitely the peripheral blood is easier, with less risks of donation, less psychosocial issues, and more convenience. In case we do not get a fully matched sibling donor in the family, HLA matched sibling donor, we also look into unrelated registries. The largest registry is in the United States, which is called the National Marrow Donor Program. We also have registries in Europe, which is a German registry called DKMS. We also have our own Indian registry called DATRI in Chennai, where volunteers come forward to become donors for stem cells. The other less commonly used source is the cord blood, where volunteer families come forward to preserve the baby's placental blood, which is rich in stem cells in cord blood banks. Once stem cells are collected, it has the advantage of the ability to store these stem cells in liquid nitrogen even for many years, and they remain viable all these years. Definitely, donation is safe, unlike a solid tumor transplant where the donor has to donate a part of their organ. In stem cell donation, generally stem cells get repopulated in the donor's body within the next 48 hours, and there is no serious risk to the donor. This is something I discuss all the time with patients. Why do we need to transplant you? In a congenital or a immune compromised status, like a disease like a thalassemia or a aplastic anemia, why we need an allotransplant is just to replace the defective hematopoietic system, or to overcome the defective immune system. In a malignant disorder, there's an acute leukemia or a lymphoma or a myeloma, the reason for transplanting is slightly different. Cancers are variably sensitive to chemotherapy and radiation, and if you are able to deliver a higher dose of chemotherapy or radiation that we do before we transplant patients, resistance of these cancer cells may be overcome, and we may be able to see more cures. However, the high dose of chemotherapy leads to marrow toxicity, and this marrow toxicity leads to marrow ablation, which can be rescued or overcome by using incoming healthy stem cells. If you see this graph, the y-axis, if it is indicative of disease burden, the x-axis is indicative of time. Once the cancer patient comes to us for care, we initially cytoreduce the disease burden with initial chemotherapy. When the disease is at its weakest or when the disease is in remission, we use this time point as an opportunity to transplant to eradicate resistant cells that may, over a period of time, lead to relapse if you don't do a hematopoietic stem cell transplant, which could be both either an auto or an allo transplant, which I'll allude to more in the subsequent slides. A typical cancer therapy compared to transplant is slightly different. In terms of a typical cancer therapy, generally is a one-step process where you either give chemotherapy or a radiotherapy or immunotherapy or a targeted therapy. In a transplant, it's a three-step process. You treat disease with high-dose therapy, treat the bone marrow toxicity with the incoming stem cells, treat disrupted immune system with antibiotics, immune suppressive drugs, and vaccines. The indications for hematopoietic transplant are varied. You have myeloma, which is the most commonly transplanted where you use auto-transplant. Other commonly transplanted diseases include acute myeloid leukemia, thalassemia, aplastic anemias, lymphomas, myelodysplastic syndrome, and few solid tumors like neuroblastoma or relapsed germ cell tumors, immunodeficiency disorders, myeloproliferative disorders, etc. This is the process of transplant. We confirm disease remission and patient's fitness by looking at organ functions. We do a HLA typing. We collect stem cells from the donor, and the patient gets high doses of, very, very high dose of chemotherapy and radiotherapy in some patients. The stem cells from the donor are processed and cryopreserved in low temperatures, and they're reprocessed and infused back into the patient after the patient has received high dose of chemotherapy and radiotherapy. This is the initial steps that we do when we do a transplant. The y-axis shows the white cells at the platelet count before the transplant, and once the chemotherapy is delivered and the patient is shifted into the bone marrow transplant unit, there is marrow toxicity and the counts crash. And on day 0, which is the day of transplant, we typically call day 0 as the day of transplant, we give the stem cells into the patients. These stem cells go and the stem cells are given just like any blood transfusion. And they go and repopulate the bone marrow, and the white cell count increases in the next 15 to 20 days. During this period, patient requires blood and platelets from outside and antibiotics to fight fungal, bacterial, opportunistic infections, and antivirals too. The auto transplant is similar in many ways, except that the donor is the donor for the stem cells is the patient himself. Once the disease has come under control, there is an initial process of collection of stem cells from the donor and cryopreservation. And after that, patient receives chemotherapy and his own stem cells are reinfused into the patient after the chemotherapy is delivered. It's important for referring physicians to remember that once the patient has relapsed multiple times, the outcomes of transplants are poor, and it is important to remember to refer patients early to a transplant center and plan transplant if it is indicated. Once a transplant is done, there is a combination of things that we look into, which include opportunistic infections, graft versus host disease, which is a major complication that one can face post-transplant, and a possible relapse. And a significant number of patients are cured with this procedure, with this complicated procedure. Otherwise, they wouldn't have if they had not gone through the process. Coming to a few stories, this is an Iraqi war veteran who lost both of his hands during the war, and the surgeons did decide to transplant his hands from a brain-dead donor. And however, as you know, the immune system definitely rejects a foreign hand. They simultaneously did a hematopoietic stem cell transplant from the brain dead donor, and the body did accept both the limbs. And it's just an interesting story. This is not very often done, but something to take home. There are few patients of HIV that have been cured, especially if the donor is a CCR5 mutated, that is seen in 1% of the population. The HIV requires the CCR5 protein to go into the lymphocytes. And if the donor is a CCR5 mutated person, you are able to cure even HIV with a hematopoietic stem cell transplant. That, again, that is something of interest, but it's very rarely done because of lack of the right donor. If you see the number of transplants being done in our country, started in 1983, we do about 2,500 transplants every year. There was a dip in the numbers because of COVID in 2020. However, the numbers are likely to go up over a period of time. There is a significant number of patients who do not get a transplant, though they require it even in the West, especially because of lack of the right donor who can donate the stem cells. Here comes in the new advance in stem cell transplant called the haploidentical transplants, where you have, even if there is a 5/10 HLA match, you can transplant these patients from a half-matched family donor. Because of the availability of donors, these stem cells are generally cheap. There are no waiting periods, and donors inside the family are generally motivated. The science of haploidentical transplants are getting better. The outcomes are equal nowadays to matched unrelated donor, and this does solve the donor shortage problem. If you see the numbers in India, the green bars show the increase in number of haploidentical transplants being done in our country each year. This is similar in the West, where the yellow bar shows the increase in number of haploidentical transplants being done in various parts of the world. Coming to the more practical aspects, the cost and the availability, if you look at auto transplant, the cost is about 8 lakh rupees in most of the centers in the country. And there is a post-transplant cost is minimal when you look at auto transplants. If you have a fully matched sibling donor, which is an allogenic transplant, the cost is about 12 lakh rupees. You also have to look into average post-transplant cost once the patient goes home after the transplant is about 5 lakh rupees. Haplotransplants are more complicated, more intense, where you need a little bit more money, 16 lakh rupees for a transplant procedure and about 10 lakh rupees for post-transplant care. We have about 10 major centers for hematopoietic stem cell transplant in Karnataka and about 80 major centers. Though more smaller centers are coming up who are doing more of auto transplants and trying to progress to allogenic stem cell transplants. 90% of these transplant centers are located in corporate hospitals, and there's a need for academic centers for coming up with bigger transplant units. Coming to our own data, we started in 2013 in the wards, and we built a transplant unit, 4-bedded transplant unit in 2015. And since then, we have worked towards more patients. And if you look at the last year's numbers, we hit close to 25 transplants with all types of transplants, including haplotransplants, sibling matched identical transplants, and auto transplants. This year, we have done majority of patients we have transplanted are haplotransplants, and we hope that we hit a bigger number this year. Coming to our publications, our unit was highlighted in the American Society of Hematology meeting in 2019 in their Global Capacity Building Showcase. And we continue to persevere to publish in high impact factor journals, both in the transplant area and also in oncology. This is an image of the bone marrow transplant unit, which has air-conditioned, HEPA-filtered clean rooms, 4 of them. And this is a typical transplant suite where you have a television and oxygen suction and a comfortable bed and a large room. And this is the image of our team. I thank them for all their support for a period of many years now. And I thank my alma mater for molding us into whatever human beings we have become over years. Thank you.
Thank you, Dr. Santosh. That was an excellent talk and journey of stem cell transplants you have shown a very beautiful way. And taking cue from people like Dr. Santosh, we have also started in KSHEMA, autologous stem cell transplantation. So for the last 3 years, we have been doing autologous stem cell transplants on myeloma. There are around 20 patients so far. 20 patients undergoing transplant as we speak. So slowly, we are hopefully we'll be able to bridge the gap between the medical college and the corporate setting. And it is alumni like you who are inspiring all of us over here to follow in suit. So thanks, Dr. Santosh. That was an excellent presentation. If there is any queries from any of our attendees today, Dr. Santosh. So if there are none, Dr. Santosh, I would like to ask you what are challenges that you're facing while doing haploidentical transplants in your center in terms of graft versus host disease and other challenges, complexities. What are the challenges that you're facing?
Important challenge is definitely financial, and many times other definite challenge, especially in a non-malignant disease, is what we call as a donor-specific antibody, which increases the risk of rejection in this patient. So, and we need to reduce the donor-specific antibody levels before we take the patient for transplant. That is one challenge. And other challenge definitely is the cost. We are able to tailor the transplant regimen and able to definitely control the graft versus host disease to reasonable levels. And with the availability of ruxolitinib, we are able to treat GVHDs in much better way than previously.
Thank you, Dr. Santosh. Over to Dr. Nikhil for his concluding remarks.
Thank you so much, Vijit, for moderating these sessions, and especially I should be very thankful to you for that. And we had already faced two fantastic talks by our alumni, Dr. Santosh and Dr. Swapna, on various topics. And before going to the final function, at the end of the function, I would like to call upon Dr. Ashwin Krishnamurthy, the professor in the Department of Anatomy and the coordinator of Alumni KSHEMA, to propose vote of thanks.
Thank you, Dr. Nikhil. Okay, at the end of this particular, these two talks, I'm very happy to actually give out this vote of thanks session. It's in fact my privilege to hear such talks also. First of all, I would like to thank the management of Nitte University actually for providing us the platform to have an interaction with all the alumni of the college. I really thank all the management and staff of Nitte University for providing us this one. My sincere thanks to my administrators at KSHEMA Medical Academy, our beloved dean, and the two associate deans for always encouraging us to move forward with all the activities here. They also provide all the logistic supports that we need for conducting these activities. I would like to thank Dr. Swapna Devanna and Dr. Santosh Kedi. Thank you both for obliging to our request to give a talk on your work at such a short notice. In fact, it was very insightful for all of us. I understand that this is at a very different time zones. For Swapna, this is late in the night, and for Santosh, this is a very early hour. I understand that. Thank you so much for giving us your talk. We are very happy to hear your success stories. You define us. Please, on behalf of Nitte University Alumni Association, I actually welcome you both to visit us, visit our campus. Whenever you visit Mangalore, we'll be very happy to welcome you both. Thank you so much for that insightful talk. My sincere thanks to the Director of Alumni Association Cell, Dr. Prasanna Kailaje, for the guidance and support. The coordinator of IQAC and the team IQAC for constantly being with us and being co-hosts for this particular session. My sincere thanks to Dr. Sadhana Deshmukh from the Staff Development Center for providing us the logistic supports in conduct of this particular program. IT Cell, you have been with us throughout for helping us prepare for all these activities. And my thanks to all the participants who are here, who have gathered in large numbers. Thank you so much for being with us. And with this, I think we come to the end of this particular program. And if I have missed out anyone, please, it is purely unintentional. Please forgive us for this. All right. And to all the participants here, the feedback link is actually provided in the chat. Kindly give your feedback to us. Thank you so much.
Thank you, Dr. Ashwin. And so that we have come to the concluding aspect of the program. And it was a special experience for all of us. More than that, like it is, we have been planning all this from couple of time because of COVID. 2 years we could not proceed with any of the programs. And the next plan would be like we would want to organize more on site, like the alumni who are at the different level coming up to the hospital and our university and giving a talk, so that we can experience, students can experience, and it would be a real great experience for all of us. And it is glad to see all of us, especially because here are professors, dean and vice deans here. And I think if you don't have any other things, we can conclude the topic and the session for the day. Hoping that something better is coming soon. Thank you, Swapna, and thank you, Santosh.
Thank you. Thank you. It was a pleasure. Thank you.
Thank you so much.
Thanks, everyone.
Yeah.
Thank you. Thank
Yeah.
you.
Thank you, sir. Thank you so much. Yes. Thank you, Dean,
Thank you,
sir.
Santosh and Sapna.
Thank you, ma'am. It was really nice to actually see all the faces today and after so many years. So really happy to see you all.
Thank you, one and all.